So clinics care deeply about patient experience. That's common sense, right? So why does engagement still break down once patients leave the building?
Let's just imagine you're a patient and you're thinking about hip replacement. You want to go get hip replacement. So you go online and you start looking, or you ask your friends about hip replacement, and you come up with 2 or 3 different clinics. You find 2 or 3 different surgeons, and you register interest with them. You say, hi, I'm interested in hip replacement, or I had a referral to you for hip replacement, or you did my brother's hip and I'd like you to have a look at my hip as well. From that moment in time, as soon as that inquiry goes, they are, forget from a clinical perspective, from a customer perspective, that customer is under your supervision. They are under your supervision as a lead. They are under your supervision as a consult. They're under your supervision as a consultation progression to a treatment plan. They are under your supervision for surgery, post-operative, a year later, 2 years later, maybe the post-op, they go to the gym, they bend over, their hip pops out. They're still under your care. So as a healthcare practitioner, in some ways, you have a lifetime care responsibility that goes well beyond intervention, surgery, or acute provision. So now you've got a relationship with someone that spans not weeks, not months, but years, and in some cases, decades. Now, you have to think about that compounding over time. You have hundreds of patients in the first few months of your practice, thousands in the first few years of your practice, tens of thousands as you get bigger and as you grow, but your team does not grow in size. You don't suddenly have a team that can support 100,000 patients. You have a team that is constructed to support a fixed number of patients within the physical premises. So you have an ever-growing community of customers, patients, that seems to be getting bigger and bigger, but your team cannot support those patients. So one of the problems here is that the supply and demand mismatch gets worse as you get bigger. There's a private hospital that we're looking to work with. They've got 100,000 patients that haven't heard from them in the last 12 months. 100,000 patients, leads that were lost, consultations that didn't progress. Those patients cannot be supported by the same team that is also supporting patients in care. So one of the challenges around providing that ongoing patient experience is simply capacity. You just don't have the people to provide that high-touch support. Now, you could say, throw the AI at it, throw the agent into it. That's fine, but the agent is not going to offset the care responsibilities of the practice. And so unless that agent is able to go end to end in managing the patient body, there is still a finite ceiling on how many patients that team can actively support. And that is one of the issues. You have a supply-demand mismatch, you have a capacity constraint. Problem number one. Another huge problem is that you don't have the technology in-house to deliver patient relationship management at scale. Patient relationship management is not a CRM problem. We have clinics that use everything from HubSpot to Pipedrive to Go High Level. There is an extraordinary amount of software fat around the clinic. They use Boxly or Denflow or LeadGen to capture their lead interest, to try and maintain some continuity of care. That is not the solution to solving for patient relationship management. It's not the way you solve for patient experience. It's a workflow tool. It allows you to capture the people and move them from A to B, put them on the automated email sequence. The automated email sequence doesn't work. People don't read their email. People are not interested in your monthly mailer. People want a personal patient coordinator in their pocket. They want to have one message away access to your front door. And there's too much friction in the way. And so you get patients, and we see this all the time. We reach out to a patient community. We just say, hey, how are you? We haven't seen you in a while. And they write back the craziest things. You wouldn't believe it. They say, oh, it's so wonderful to hear from you. I can't say hi to Mark for me. Say hi to Sue for me. Oh, the team is so wonderful. Or they write back and they say, I had a terrible experience. I asked for my x-rays 6 months ago. You still haven't sent me my x-rays. Clinic has no idea. Clinic has no idea that they have patients under their care who are still waiting for things. That is a huge problem. And even though you might have the CRM, using it and making it work for you is a completely different problem. And we know this because when we take over a practice and we start managing patients on their behalf, a huge number of patients don't even have the right contact details. You reach out to someone in the CRM, it says David, you reach out to them, they come back to you, say it's Sarah. Like, you've got patients in your CRM. You have no CRM hygiene. You don't even know if the client account records are accurate. So you can't possibly nurture and provide that one-to-one relationship and deliver that experience outside of the physical clinic. And I think that's, at the end of the day, the thing that healthcare providers often miss. 99% of the care journey does not happen in your clinic. They come in for surgery, great. They come in for a treatment, great. What about the hours, days, weeks, months in between their visits? They're still under your care. You need to extend the care and the support to them when they're not physically there. That is the difference between I go somewhere to have someone look at my back, and these people really care at me. They really care about my continuity of care. They care about my outcomes. When I feel that sense of care, I tell my friends. When I feel that sense of care, I go above and beyond to commit to that practice and go on that journey with them for the long term. So extending that experience is not just a team problem, and it's not just a technology problem. It is a team and technology problem together. And providing that solution as one is why practices can't just do it themselves with another hire. And that is the problem that we ultimately try and solve for practices.
Would you say that PRM sits in between PMS and CRM, also from multiple dimensions of team, technology, people, technology, as well as workflow, is almost like an intersection of all these things?
I think if you look at patient relationship management, it is a fundamentally different thing than practice management. Practice management is a business efficiency tool. Patient relationship management is an engagement and nurture tool. They're different. And because they're different, the way the products are built look different, feel different, interact with the user differently. I'll give you a simple example. You go into your practice management software on a Monday afternoon, you say, I want to notify my patients of a new service that I offer. So you go to your patient body, you draft up an email, you press send. That's your practice management software workflow. 90% of the people you just send that email to will never even open it. Of the 10% who do, most of them won't get past the first line. So practice management software is about, I sent it. I did the thing. Great, you've done the thing. And what's the outcome? What came back? How did patients respond? So practice management software, I can take the action, I can send the thing, I can communicate outbound. But what time of day did that email go? Do you even know? Do you even know if 11:04 or 12:03 on a rainy day or a sunny day is better? Should you be sending that message after payday at the end of the month? Should you be sending it at the start of the month? Should you be sending it after an SMS? Should we send it before WhatsApp? You have absolutely no visibility.
So omni-channel element as well.
There's no intelligence behind the communication. I often say when we speak to practices, they say, what is the difference between you and my practice management software? And we'll say, your practice management software is dumb communication. And what we're trying to do is smart communication. It's not to say that dumb communication isn't good. There's value in dumb communication. Dumb communication is, you have an appointment, your appointment's tomorrow. Great, helpful.
Transactional.
Very transactional. Dumb communication is transactional. Smart communication is nurture-based, timing matters, channel messages, message matters. It's emotional. People receive messages from us and they write back saying, oh, it's so wonderful to hear from you. They then go into clinic and they say to their practitioner that they haven't seen in 3 or 4 years, it was so nice to be reached out to. So if you want emotional activation, this is not a systems problem. This is an intelligence problem. And you have to solve that with the purview of intelligence. You need to find a way to communicate with patients that makes them feel warm and supported the same way they would feel when they're physically in clinic. And so a huge part of our job is to understand and interpret and codify the brand. Oh, you're a practice that is more playful, more entertaining, has a fun and joyful relationship with your patient body. That is how we will communicate with your patients. Oh, you're more serious and surgical and you serve a slightly older demography and your patients are perhaps spending at a slightly higher price point and they're accustomed to hearing from you in a certain way. They like the address dear patient as opposed to hey patient. That nuance in communication makes a huge difference and it resonates with the patient because they ultimately invested in the brand, because the service itself is often commoditized. I can go to this dentist, I can go to that dentist, but one of them is going to activate me as a patient and I'm going to forge that relationship with the practice. We are trying to extend that communication in a way that nurtures the relationship. The consequence of doing that is not just revenue and rebooking. Revenue rebooking is one thing. Feedback from patients is another thing. Continuity of care, referral, positive reviews, All of these things amplify the clinic's presence and allow you to achieve that front office transformation.
So now you talked about, let's say if PMS is the transactional, it's almost like sending emails, right? There are two kind of emails. One is transactional, one is like marketing emails, right? Every
100%.
SaaS company have that. So transactional email, you use SendGrid or XYZ, right? And then marketing emails, you use HubSpot, whatever. So we talk about PMS versus PRM. What about PRM versus CRM? Why you think CRMs, you touched on this before, like horizontal tools such as HubSpot, Salesforce, MailChimp, all these horizontal catch-all CRMs, why they can't deliver value that a PRM, essentially Coherent is the PRM platform, right? Why you don't think CRM is in a position unique enough to deliver the same outcome?
Yeah, look, part of the problem in healthcare is interoperability. How do I move between systems? And do my systems talk to each other in a way that makes sense? So I'll make that very simple. Let's say you're using HubSpot. Question number one is, can I connect HubSpot to my PMS, my EMR, EHR? Maybe. Let's say that we can. In many cases you can't, but let's say that we can. In cases where you can, is the data that feeds back from the PMS, EMR, EHR actually informing the work that you then do in your CRM? Or is it just that now you have a single customer record? Great to move the customer record across, but is HubSpot configured in a way that identifies specific points in the treatment journey that are more or less likely to result in drop-off or churn? And more often the answer is not. So you can get this one-to-one relationship, so you have a single view of customer, but they don't talk to each other in terms of actually delivering value. They talk to each other, again, in a sort of dumb way. There's an integration, but there's not necessarily value. We have a clinic that we work with that uses Zenoti, which is a terrific PMS in medical aesthetics, but they also use Pipedrive and they also use Klaviyo. And so now they have 3 sources of integration, customer records in 3 different places, and they're trying to manage discrete parts of the workflow in each of these different tools. And you can imagine that it is an absolute nightmare to do that because the tools don't talk to each other the way they want. So one of the issues is integration and interoperability. Another huge issue is just the fact that usually the systems of record, the PMS, EMR, EHR, are just old. And because they're old, they're not integration API first friendly with the HubSpots of the world or the Pipedrives of the world. They're not built in that way. And so I'll give you another example. We work with a dental practice right now who use a legacy dental practice management software that is on-prem, not cloud-based. So in order for us to deliver our service, we need to remote into the desktop in clinic and rebook patients directly in as a desktop user. Please tell me what CRM tool is going to enable that. None will, because CRM is a software-only platform. Software-only platform means someone in the clinic needs to push the buttons. And as soon as you ask the clinic to push the buttons, nobody pushes the buttons. Because CRM has existed. This is not a new category. HubSpot's been around for a long time. Salesforce has been around for a long time. Pipedrive's been around for a long time. CRM tools exist. The user doesn't. And so CRM and PRM are different. Patient relationship management is something that's done for you. Relationships are actively cultivated, nurtured, and developed. In CRM, it's a workflow tool, but you have a real problem because the CRM requires you to have someone there actually doing the work. And the problem in most healthcare practices is that person doesn't exist. It's not a receptionist. It's not a front of house admin. It's not a booking coordinator. Those people are very talented. They are not CRM specialists. And so PRM is like CRM as a service. It's actually doing the work of managing the patient relationships and then handing that information, that value, that rebooking, that revenue, that insight back to the practice in a very consumable format. That is the difference between those two tools.
Would you say that an active personality that basically covers both human and possibly in the future AI agents would be the main differentiator here, right? You're talking about done for you, but also there is a tool element. But more importantly, when it comes to relationship, it's not a tool, it's not a button to push, it's not a transactional email, but there is a personality, AI or human, on the other side to develop that relationship with.
Yeah, I think it's a great way of thinking about it and a good example. So when we work with a practice, what we often see happen is when the patients go back to clinic, they will ask about the person that contacted them. They will say, oh, I didn't know Sarah joined your team. Oh, I didn't know John joined your team. I didn't know Tandy joined your team. I didn't know Sonia joined your team. They are thinking about that encounter with a personality. They don't know that personality is physically on site, not physically on site. So they are interacting with a person, an identity, and that identity is reinforcing the relationship. If you think about a clinic using a CRM tool or PMS, they're not coming into clinic and saying, oh, I noticed you use HubSpot. I saw that you emailed me with HubSpot. They're not doing that. That's not there's no relationship there. So you can deliver the workflow, but you can't build the relationship. We are trying to put a patient coordinator in your pocket so that every one of your patients wakes up in the morning and says, oh yeah, I need to do X. And because they think they need to do X, they have a way of acting on that is minimal friction. It is send a message. It is in their communication channel that already exists. So there's no new jobs to do. Oftentimes we see patients needing to access a patient portal for their practice and log in 4 times and have SSO with a sign-in link in their email. Nobody has time on that. You can go on Amazon and buy oat milk, whole wheat spaghetti, and running shoes and have them delivered to your house the next morning at 10 a.m., but it takes you 3 hours to get through to make a doctor's appointment. There's a fundamental breakdown in how we've constructed that on-ramp. And I think in healthcare, a lot of innovation focuses on fixing the front door. Fix the front door, fix the front door. And I think there's a problem with that because the front door is in the wrong part of the house. So you can fix it all you want, but actually the front door is not something that should feel like a high-intensity phone call with wait times. The front door should feel easy to access. It should feel one message away. It should feel like messaging your friend. It should feel like messaging your partner. It should feel like messaging your relative. That easiness is what unlocks access to care. It builds an on-ramp that makes sense for the patient. And that is very different than what you get with an off-the-shelf tool. You want something that is human and accessible as opposed to formulaic and process-driven.
The way I look at it is that reminding a patient is transactional. Reactivate a patient there's a million things. There's commercial aspect, there is discovery, there is support, there is engagement.
I think that's right. I'm trying to think of my own experience as a patient. So I went to a dentist recently. I just moved. I went to the dentist recently and I went in for hygiene. And when I walked out, they said, thanks for coming in. It would be great if we could see you again in 6 months. I walked out without an appointment. Haven't heard from them since. This is 2 months ago. I'm absolutely positive that a month before the 6-month period, I will get an SMS and an email that says, hi, Jared, it's time for your dental checkup. Click here to book. Call us to book. And then I'm pretty sure that if I don't book in 2 weeks, I will get another email. I will get another SMS that says, hey, you're overdue. It's time for you to come back in. And then I imagine that 2 or 3 weeks after that, I'll get a phone call. And then I imagine that 2 or 3 weeks after that, I'll get another email. And if they're great, I might get another 1 or 2 emails or WhatsApp messages. And so maybe I'm on a 3, 4, 5, 6, 7 touch point reminder cadence around my dental hygiene. There's a problem with that. And I think a lot of that problem is around the patient psychology. So the patient psychology, and we hear this from our practices all the time, the patient psychology is not one that feels good about being late or about not coming back. We have a chiropractor that we work with who has said many times over that sometimes some of their best patients don't show up for a couple of weeks, maybe they disengage for a couple of months, and then they actually start to feel bad. They start to feel judged. They start to think, oh, my chiro that I have a great relationship with is upset. And so I'm just not going to deal with that social conflict. I'm just going to go down the block to a competitor and do something different. And I won't have to deal with that emotional baggage. Reminder cadences, as opposed to reactivation, reminder cadences, there's real risk in creating a sense of guilt and overwhelm and disconnect with the practice. That's a problem, right? So if I go in for a treatment of a certain type, we have patients that go in for treatment of a certain type, when they get it's been 3 months since your last thing, it's been 6 months since your last thing. This is deficit mentality. This is, you are doing something wrong. You are late. It's time for you to come back. That is not reactivation. That is procedural. And oftentimes it is to the detriment of the relationship with the patient. And it's why when we start working with practices, they say, oh, we've already got a recall program. These are the emails. And we go and we look at the emails and we say, turn all of that off right now. Stop all of it. First of all, we don't want to double communicate with them. But second of all, there's no benefit to you to sending out a generic email, a generic SMS saying, it's time for your thing. Patients, I know I'm supposed to go into my dental hygiene in 6 months. You telling me 16 times as an appointment reminder feels like homework. Feels like what you get in school. Your assignment is due. Your assignment is due. Now your assignment is late. There's no incentive for me to become a better actor. And so there's a difference between that reminder and reactivation. Reactivation is, we're going to help you back into a care pathway. We're going to make it so easy and joyful for you to come back into a care pathway. So I'll give you a very simple example. Again, in the case of my dentist, I know I'm going to get a reminder sequence. I'm probably going to ignore that for 6 to 12 months. At some point, I'll go back in because I'll say, it's probably time for me to do hygiene. A completely different form of re-engagement, something that falls into the category of reactivation, is if that message to me is deeply personal. Hey, we saw you a few weeks ago. You mentioned XYZ in the appointment. We wanted to follow up on your filling thing, whatever, that was a particular area of concern. I remember that your gums were very sensitive, and we want to make sure that there's no issue there. And hey, by the way, how wonderful that your partner and your kids have also joined the practice. The emotional response for me as a patient is completely different. It is about building that vibrant, authentic relationship with the clinic rather than a place of administration and something that I just have to do in the background. And I think this is what's missing from the care continuum. And it's something that's really happened in an impressive manner in hospitality. When you book a holiday with a 5-star hotel, you're almost excited about getting there before you even walk in. They send you pictures and videos of the beach. They tell you about their great buffet, the lobster and the sirloin and the vegetarian special. There's an excitement that comes around hospitality experiences that does not happen in healthcare-based experiences. And that is a shame. Now, partially, being in clinic is not always as enjoyable as being on the beach. One can appreciate that. But also, the communication and experience around the healthcare has become a place of administration, has become a place of slowness, has become a place of lethargy. Like, we are trying to overcome those stereotypes. We're trying to create a situation where patients have that ease of re-engagement. And in order to make that easy, the message matters. Not just the timing and the automation, but what, how, when these things work together to establish vibrant relationship with the patient. That is patient relationship magic, which is quite different than sending a reminder note. I think a lot of healthcare providers are very indexed to providing VIP level experience when you're on site. When the patient is there, they are very focused on the tea and the coffee and the joy and the smiles and the relationships. They're very focused. It's very physical. It's very embodied. You are here. We are with you. Let us make this special for you. And they're usually very good at that because I wouldn't say it's easy. It's not easy, but it's non-technical. It's someone there. And because they're there, we can provide that level of interaction. The question is, how do you extend that? How do you take VIP and make it remote? Because ultimately, you're competing with patient attention. And as soon as they walk out the door, they either think about coming back or they don't. They either think about you as the trusted source of healthcare-related information or they don't. And every time they think about going elsewhere or they consume information from someone else, you are taking churn risk. You are taking on the likelihood of disengagement. And so how do you say, this is 5-star in clinic. How do I get 5-star out of clinic? And I think that is, in many ways, the missing piece. How do we extend healthcare to the patient's home? Oftentimes you might call it remote monitoring, but remote monitoring has a very narrow focus, and that focus is on the clinical follow-up around a certain care pathway, which is in some ways part of extending care. But not only just extending the care, how do we extend the experience? How do we make what you're doing at home as enjoyable as what you're doing when you're physically here? And many patients don't have a strict healthcare regime at home. And so the way you extend is micro movements, small nudges, small touches. We thought of you today. How are you feeling? It's been a few months. Do you need anything? Making sure you've got that follow-up, that referral that'll come through. That one-to-oneness is very hard to deliver in a remote format. And that is ultimately what we're trying to give practices, is those sort of superpowers to move their care provision, that VIP experience, into the next layer, into the home.
Yeah, I think especially as a clinic scale, as they grow, they lose touch of that original, how they started as almost like a family,
100%.
friendly,
Totally.
down the street,
Totally. Yeah.
GP,
Yeah.
that family doctor vibe. As they grow, especially for ambitious clinic owners or directors, or they grow into multi-clinics, multi-location sites, etc., they lose touch of that completely. And there is lack of budget, but more importantly, lack of infrastructure or technology or expertise to create that at scale. So it's almost impossible, right?
100%. We've got a clinic that we work with, phenomenal clinic. I won't mention names, but I would argue if you are in the world of medical aesthetics, dermatology, private GP, holistic wellness, I imagine you won't find a better practice. And one of the things that's so interesting about their patient cohorts is that their strongest retention cohort, so the patients who've stayed with them the longest, are patients from 2017. Why? Because in 2017, the principal practitioner saw every patient, and the now practice manager saw every patient. And so they were able to deliver a quality of experience that you only see with the founder and the director and the people who put their blood, sweat, and tears into the clinic. Unfortunately, that's just not everyone, nor can you reasonably expect it to be. So they've got patients from 2017 who are still with them. They've got drop-off in some of their later cohorts because as they brought more people into the practice, processes get harder, one-to-oneness gets harder, management of the patient body gets harder, unhappy patients are harder to spot. People walk out, they're not happy about something, you never know. You need eyes and ears into thousands of patients. You cannot do that in-house. You do not have the team, the tech, the time to manage 10,000 patient relationships as a team of 20 people. It's not possible. So we speak to clinics and they say, we're going to hire someone to do this. Great. Enjoy. How many rows is on your spreadsheet? It's just not possible. You can't provide that kind of continuity of experience when you have someone sitting behind a desk doing 5,000 other things. You can train them until they fall over without the right tools in place. They're going to fall forward. And if you do have the right tools in place, then you need a team to go with it. And then that team goes on holiday, that team gets sick, that team turns over, that team leaves, all the SOPs are in their head, they walk out the door, SOPs go with them, you start again from scratch. Oftentimes when we work with practices, we sit down, we document the SOPs as part of our onboarding. We say, this is your booking procedures. We give it back to them. We say, is this right? For some of them, it's the first time they've ever seen their own SOPs. They say, oh yeah, we used to have a thing that when we opened our doors and we had a document and we said, this is really helpful. Yeah, of course, because it's now you're booking people in, but you don't have it written down anywhere. That's the reality of being in clinic. Reality of being in clinic is you're going from fire to fire. You can't also be focusing on thousands of patients who left last week, last month, last year, while you are putting out fires in clinic. It's just not possible.
Would you say that the reason why they're not doing relationship management, at least not focusing on relationship management, is because two reasons. One is that they are surviving. They are surviving either profitable or busy or both, so that they don't need it. It's not like a hard requirement. Would you say that's the reason? Or maybe they can hire someone to look after a number of patients. So basically, it's a cost problem that they just have to make more money to cover the cost. What are your thoughts?
This is a blunt instrument, but I will always say to clinic owners, they say, oh, we don't have this problem. How many people are sitting at your front desk? That's the question. Do you want to know if you have a problem? The question is, how many people are sitting at your front desk? If the answer is more than one, you have this problem. It's very simple. If you have a front office operation that requires something any order of magnitude greater than say hello to people, give them a drink, make sure there are no issues, answer the phone on occasion, deal with someone walking in the door. If you need more than one person there, you have this problem because you are trying to coordinate all this activity out of a single desk. And many of the clinics that we work with, 3, 4, 5 surgery dental practice, they've got 3 people sitting at the front desk. What are they doing? What are those people doing? That's not a disrespect. It's a very important job, but what are they doing? They're not engineering the data to re-engage patients. They are putting out occasional fires, having small talk, chit-chat here or there, dealing with patients as they come in, thinking about CQC compliance, thinking about whatever else is the next thing tomorrow. You have a problem if you've got more than one person at the front desk. That is and should be a hospitality-based role. It has become everything else. And so I think if the question is, how do I know or how do I identify if I have a problem? Look at how many people are sitting at the front desk during core clinic hours. You should be able to, much like a restaurant, so I love the kitchen analogy, much like a restaurant, you don't have one waiter per table. You don't have one wait per table. You've got, in some cases, one serving 15 tables, certain serving 16 tables. There's no reason that a single person at front desk should not be able to serve 15, 16, 17, 18 patients that are sitting in clinic at that point in time. And that's a big front office.
You've got 18 patients sitting at one point in time. You're basically moving into private hospital territory. There's no reason you should not be able to serve that number of people with a single front office representative, provided that all the other stuff that front office representative needs to do is taken care of for them. Have they paid a deposit? Has the deposit been checked off in the PMS EMR? Has the patient intake been completed? Et cetera, et cetera. If all that work is done, you don't need 3 people at front office. You probably need 1 person, because otherwise they're walking into nothing. So unless you're going to automate the front office and stick a robot at the front desk, which doesn't seem likely right now, you probably need 1 person. But if you're talking about going from 3 to 1, 60 or 70,000 pounds of headcount cost reduction. 60 or 70,000 pounds of headcount cost reduction. That is an enormous transformation for a clinic doing 1.5, 2 million pounds in turnover. That is the difference between a new service line, paying off debt on a machine, thinking about expansion or renovation. 60 or 70,000 pounds a year is P&L level impact, far more than a few more patients, far more than a bit more marketing to close a bit more. This is bottom line. It's not top line. This is bottom line. You move from 3 front of house team members to 1 front of house team members on core shifts. You have fundamentally changed the economic profile of your clinic. That is what success should look like.
From business owners' perspective, their goal is to extend the LTV of a patient from business angle. Of course, if the patient, like you also talked about it before, where when the patient journey finished, great, happy ending, right? But most of them are not one-off thing.
It's almost never a one-off thing. Let's be honest. There's almost nothing that you do in healthcare that's one-off. That is the reality. There are some services that are one-off. I'll give you an example. You are working with a fertility practice. You have 1 child, maybe you have 2 child, 3 child, 4 children. At some point you stop having children. That's probably the end of your journey. By the way, that's like a 5, 6, 7 year period, right? So hell of a long lifetime value of that patient body. But most clinical services are not one-off. That is the reality. You go in for oncology, respiratory physician. If you went to see a respiratory physician during COVID and you had short COVID, very long COVID, unless you had immediate COVID intervention, why wouldn't your practitioner want to reach out to you in 3 years to say, hey, how are you feeling? I'm not a clinician, but what is the likelihood that some of those symptoms, some of those concern areas persist for 3 years? Really high. So on a clinical basis, you should want to follow up. And most practitioners that we speak to do. Most practitioners do want to follow up, but they just can't. They don't have the time, they don't have the tools to do that. But there's no reason not to follow up. You take your kid to a facial specialist to look at a bruised cheek. They say, everything looks fine. We're not going to do an MRI because he's 2 years old. But let us know if there's a problem in 3 months. 3 months go by, the parents are busy. They don't remember to follow up. What if there is still an issue? Practitioner doesn't follow up. They don't even know to follow up. 3 months have gone by, life is busy. So when you think about that LTV extension, patient lifetime value is decades, not months. It is years and years, almost irrespective of the clinical specialty. It is an extremely long-term journey. And oftentimes, I think practitioners and healthcare providers think they'll stay with us for a couple months, couple years. We have a chiropractor that we work with. They say PVA, patient visit average, is X. And we usually keep them for 12 months. What is this? Suddenly their back never hurts again? Suddenly they stop exercising and they never throw out their back? They never need to come back again? Of course not. That reactivation might be 3 years away. That reactivation is still very relevant. You can't go cold on a patient for 24 months and expect to be top of mind. They might think back about the time they spent with you, but it will take a lot. They'll need to be in quite a lot of pain to do that. They need to cross that threshold of, oh yeah, I need to start my care again. If there's a relationship that exists, you don't need to wait for that severity in the clinical pain to come back to clinic because it's easy. It's easy to say, hey, everything okay? Haven't seen you in a few months? Checking in on you. Oh yeah, actually I was just this and that and I have this problem and I was thinking actually I should come back. Yeah, I really appreciate the nudge. The number of patients who say that back to us, I really appreciate the nudge, is just shocking. What have they been receiving from practices up until that point in time? Snail mail? A letter in the post? So it is a time for your reminder for your... That is not activation of lifetime value. That is just, I'm following my process. I'm following my process.
Essentially describing passive patient management and active patient management. But the funny thing is most clinics or owners or operators think that they're actively managing, but there is level to that, right? In terms of from passive to active.
100%. So I think internally, at least at Coherent, we'll often talk about active patients under management. So active patients under management means how many patients are we currently actively engaging with that are communicating with us, even if what they're saying is, thanks for checking in, everything's fine. Trying to extend, build, develop that relationship to prevent revenue loss along the journey, but also to ensure continuity of care. That is active. Active means you are thinking ahead of where the patient journey is. You are trying to take an action in anticipation of a possible clinical need, not 3 months have passed. And so time is the measure of whether or not I should do something. In fact, it should be about the patient journey. What about the patient is telling us that there is now something that needs to happen? That's a very different approach than time as the measure of re-engagement, when in fact it should be patient as the measure of re-engagement. And so oftentimes, great example, we do post-consultation follow-up for a clinic. So patient will go in, have a consultation with a practitioner, and they'll receive some medical note. This is what we think you should do to address this concern. They walk out the door. These are big decisions, 10,000 pound decisions, 15,000 pound decisions. They go home, they talk about it with their partner, they think about it. Maybe they get one email, maybe they get one phone call, and then support stops. And that patient may think about it, ruminate on it, consider it, and then they start looking for alternatives. Ooh, I think that was a good idea, but maybe if I go to Turkey, I can get it done at 7,000 pounds. Maybe I go overseas to do it. And there's truth in that. But also, part of the disconnect is that there isn't the appropriate support to bring the patient back in. They may have questions. They don't want to ask you more questions. Will you answer their questions for free, or will you charge them for additional time and consultation? That shopping around doesn't have to happen if you provide extended care, if you continue the consultation all the way through to when the patient goes home, days later, weeks later, months later. Same with cancellations and no-shows. People don't show up. You think, oh, I keep a card on file. I can charge you when they don't show up. Great. That's how I'm going to build my patient relationship. I'm going to charge people when they don't show up. That will be the end of the patient relationship. Oftentimes, patients don't show up because they forgot, because they weren't nurtured, because they weren't supported, because they're afraid of missing something else. So when you think about overlaying active patient management, you're trying to be on the front foot of these problems, as opposed to reacting to the fact that a patient doesn't comply with the correct path. And I think also, you talked about before, practice management software, it's really good at forcing patients into your process. They don't show up. Ding the card. They don't show up. Charge them. That's a time waster. That person, they're not high intent. That person comes in and never follows through. And of course, there's some truth in that. But equally, do we actually know why the patient has disengaged? Because what we come to discover in some of our patient outreach is that the answer is, oh yeah, I'm waiting on something. Oh, I had a really bad experience with so-and-so. I was unhappy with my results. But the practice is sitting there thinking, that patient, forget them. And the patient is sitting there thinking, that practice, forget them. There's no continuity. There's nothing bringing those two people together. And that's very much the glue between practice and patient, is how do you stitch together that communication?
It's interesting because there's so much competition, right? The same, like you said, shopping around is very common. Like even when you speak with practice owners, they will say, oh, we're trying to rank on top of Google, making sure that we outbid the other competitors in the local area. Essentially, what you're describing was the patients considering the possibility of medical tourism. The patients essentially, what you're saying, bring them into the relationship or nurture that relationship, is about the patient was essentially paying a premium for having a better relationship. And that's what they're paying. They're paying for the relationship, not just the clinical outcome, because they can do that
anywhere
at a much cheaper, much cost-effective.
Completely. Yeah. The service itself is often, and this will be very offensive to practitioners, and I'm sorry for that being the case, but the service itself is often commoditized. There are some practitioners who are better, there are some practitioners who are worse, but oftentimes the service is commoditized. What's not commoditized is the experience. The same is true in hospitality, right? The same is true in restaurants. You can go to many places and eat. Many places will give you good food. On occasion, you get the 3 Michelin star, which is unique and you can only get it there. But more often than not, this restaurant and that restaurant are not that different. But what makes it different? Connection, experience, brand. A lot of that happens outside of clinic. And this is the difference. We often think about restaurants and clinics. The difference is that the experience you have at a restaurant is predominantly consumed in the restaurant. You go there because you're hungry, you get food, you go home, you don't think about it again. You go back if you want to. Healthcare provision is different. You go in, you have a 30-minute provision, you have a 60-minute provision, you have a surgery for 3 or 4 hours, you go home, you're still under their care. It's not like you go to a restaurant and the restaurant becomes your dietitian, follows up with you. Hey, are you eating healthily? That's not what a restaurant does. It's not the purpose of a restaurant. The purpose of a restaurant is to feed you while you're there and then to say, get out, next person come in.
Maybe you should.
It should. But the clinic is different. The clinic is about coming in for a small part of a care journey. And this is where a huge number of health tech innovators are having a field day. Wearable devices, wearable rings, they are giving you healthcare support when you're not physically with a practitioner. That is the premise of a ring that measures your heartbeat. Granted, that of course can't be provided by your chiropractor or your GP, your locum, but the relationship that you have with those practitioners can and should be extended, because at the end of the day, that person has seen you, touched you, felt you, understood your concerns. This is a very hands-on experience. So why wouldn't you want to extend that into the home? Why wouldn't you want to extend that after the patient actually leaves clinic?
Why isn't this problem solved by better software alone? But also, what do you think the role of technology should actually play in active patient relationship management?
Why is this not a software problem or not a software only problem? And I think the answer is, look at what's going on today in the market. Software has been around for a long time. Good software has been around for a long time. CRM has been around for a long time. Omnichannel communication has been around for a long time. This is not new. These categories have been built and established. They have not been adopted. Why have they not been adopted? Healthcare might be a slow adoption sector, sure. Yes, there are interoperability challenges. So there's like a vertical focus that needs to happen. But ultimately, what we think, there's no user. No user means software doesn't have a champion in-house to buy the thing and bring it in. So when you have no user, who are you selling to? Who's going to force adoption? Who's going to champion it internally? It's like trying to sell accounting software to a marketing agency. They don't care. That's why AI scribes, right? Medical scribes have taken off like a rocket ship because there's a user. The user, the clinician is saying, yes, this saves me 3 hours a day. Please give it to me. There's a user, there's a champion. There is no champion around patient relationship management. So I don't think it's just a software problem, although of course technology plays a role. The question then is, what should technology do? And our sense is that it is not to remove the human. Other people may disagree. A lot of companies, especially in the last 12 to 18 months, have come to the world and said, we are your AI teammate. We don't think clinics want an AI teammate. That is our view of the world. Maybe wrong, that's fine, but we don't think that people are looking for an AI teammate. I think what people are looking for is a teammate who happens to be really effective and really efficient. And that's exactly what we think software and technology should do. They should enable the human to take the key actions at the right time. Look at patient recall. We do a lot of patient recall. And if you segment and you really get into the thin slices of patient recall, there's a whole lot of work in patient recall that is completely administrative and in no way value add. And then at the very end, there's a unique moment where you can drop a human in and give this delightful, magical wow experience to a patient. Here are those steps. Let me identify my patients in the practice management software. Let me configure them to an omnichannel re-engagement sequence. Let me reach out to them. Let me pre-schedule SMS, WhatsApp, and email at the right time on the right day. And then when that phone call happens, let's not bring the human in right away. Let's let the phone call happen automatically, dial patients down the list until boom, someone answers, and then bring in the human. So now you've taken 10 hours of work that a human previously needed to do, and you are allowing the human to be uniquely valuable in a 10-second window to engage that patient. 9.5 hours of inefficiency, 10 seconds of brilliance. That's the model. That's what it should be. You should have 9.5 hours of AI, automation, efficiency, RPA, everything else. And then just at the right moment when the patient is ready, primed, and interested, the human steps in. Because what we often hear from the patients is, oh, you're a human? And that is the unlock. That is the aha. That's where the magic comes from. Because then we can respond authentically. Yeah, this is so-and-so. How are you? I am not giving you canned responses. I am not giving you ChatGPT answers. I'm giving you something that makes sense for the here and now, because all that busy work that had to be done to get here, I don't need to focus on. I don't need to worry about. I don't need to think about who and when and how. All that's done for me. I just have to focus on now, this moment in time with this patient. And that's where the authentic relationship comes.
Would you say the technology that powers will enable that entire new dynamic would be something called patient relationship intelligence? And if it is, maybe it's not. If it is, what would be the sort of, in a nutshell, how data is being collected, captured, and used in a smart way to enable that ultimate satisfaction of a patient from that perspective?
I think if you look at sales software, Gong, HubSpot, Clay, companies that have gone on to moves in industries, B2B outbound, very mature software, very competitive. All they do is talk about buyer signals. Buyer signals. Someone liked my thing on LinkedIn, buyer signal. Someone searched for this thing, buyer signal. We had a sales call with a company and they said 4 words and that's buyer signal. Call is automatically signal. Where is the patient signal? Where are we looking at what the patient says, when the patient says it, how the patient says it, to be able to know, that's the signal. There is no patient signal because there's no intelligence in the channel with the patient. It's locked up inside of conversation. It's locked up inside of people's brains. The thing that needs to unlock in order to create vibrant relationships with patients is signal. When does the patient signal that they need something? Because
Or
some
even
of
a
them,
picture of the signal that draws together.
or even a picture of the signal that draws it together. Because some patients will say, I have a problem. My back hurts. My shoulder hurts. I'm trying to get pregnant and I can't get pregnant. But many people have signals long before that. They evidence interest in different ways. They say things during consultations. They are communicating a certain level of concern that does not result in immediate action. And there's no way to capture, there's no way to manage that, there's no way to bring that forward to deliver value for the practice and for the patient.